High-flow nasal cannula, HFNC. Presented by Dr. Jalal, Mohsin, Uddin, M.B.B.S, D.T.C.D, F.C.P.S, Pulmonology. Assistant Professor, N.I.D.C.H. Introduction. It actually takes gas and can heat it to 37 degrees Celsius with a 100% relative humidity and can deliver 0.21 to 1.00 FiO2 at flow rates of up to 60 liters per minute. The flow rate and FiO2 can be independently titrated based on your patient's flow and FiO2 requirements. Superiority of HFNC over other oxygen delivery device. 1. Prevent dryness and inflammation of airway. Heated and humidified oxygen has a number of benefits compared to standard oxygen therapy. Standard oxygen therapy delivered through a nasal cannula or another device such as an honorary breather is cold, not warmed, and dry, not humidified. This can lead to airway inflammation, which can increase airway resistance and impair mucociliary function, possibly leading to decreased secretion clearance. Superiority of HFNC over other oxygen delivery device continue. 1. Prevent dryness and inflammation of airway continue. Also, a significant amount of calories can also be expended in individuals to both warm and humidify gas during normal breathing. HFNC can warm to 37 degrees Celsius and humidify gas, which can decrease airway inflammation, maintain mucociliary function, improve mucus clearance and reduce the caloric expenditure in acute respiratory failure. Superiority of HFNC continue. 2. Provide adequate PIF in tachypneic patient. One obvious benefit is that high flow can give you a very high flow of gas. This is important as patients in acute respiratory failure can be extremely tachypneic, and therefore their peak inspiratory flows, which may normally be 30 liters per minute to 60 liters per minute, can reach up to 120 liters per minute. So if a physician places his or her tachypneic patient with PIF rate of 120 liters per minute and minute volume 20 liters per minute on a 15 liters per minute NRB mask, the physician may not be helping them as much as he thinks. Superiority of HFNC continue. 3. Provide extra PEEP and functional residual capacity. HFNC has been shown to deliver up to 1 mm of Hg of PEEP for every 10 liters per minute of flow delivered with closed mouth breathing. Thus HFNC can increase a patient's functional residual volume, FRC. High flow seems to cause alveolar recruitment. The functional residual capacity, FRC, increases by about 25% when HFNC is applied. High-flow nasal cannula is for single patient use, maximum 7 days in the hospital, clinical environment. Superiority of HFNC continue. 4. Better patient compliance. Patients often prefer the use of HFNC than non-invasive positive pressure ventilation, CPAP or BPAP, because the tight-fitting mask can be uncomfortable to some patients. Especially patient can eat and drink with HFNC. This may lead to higher compliance with HFNC and thus improve patient's oxygenation and decrease work of breathing. How higher FiO2 is achieved. One of the major benefits of HFNC is that it gives you a continuous flow of fresh gas at high flow rates, replacing or washing out the patient's pharyngeal dead space, the old gas low in oxygen and high in CO2. Each breath that the patient now rebreathes will be washed out of carbon dioxide and replaced with oxygen-rich gas, improving FiO2. Continuous high flow. Oxygen washes out there. Upper airways. Reservoir of oxygen in upper airway, pharynx. Available for gas exchange. Avoids rebreathing of CO2 and therefore decreases anatomic dead space. Benefit of high-flow nasal cannula at a glance. HFNC heated and humidified, provides heated and humidified gas. I. Inspiratory demands, can better meet elevated peak inspiratory flow demands. F. Functional residual capacity, increases FRC likely via delivery of PEEP. L. Lighter, more easily tolerable than CPAP or BIPAP. O. Oxygen dilution, can minimize oxygen dilution by meeting flow demands. W. Washout of dead space, provides high flow rates leading to washout of pharyngeal dead space, CO2 removal. Comparing high-flow nasal cannula, HFNC, with non-invasive ventilation, N.I.D.C.H. HFNC. Large bore nasal cannula. Reduces room air entrapment. Set flow rate. Less pressure produced. Supports patients with hypoxia. NIF. Mask interface. Reduces room air entrapment. Set pressures. Greater ventilatory support. Supports patients with hypoxia. Indications. For patients in acute respiratory distress, optimizing the flow rates will ensure the benefits of the device. Flow rates of 2 liters per kg per minute appear to be safe and effective from pediatric trials up to maximum flow rates of 60 liters per minute in adults. 1. Hypoxemic respiratory failure due to pneumonia. 2. Post-extubation oxygenation. 3. Pre-oxygenation prior to intubation. 4. Acute pulmonary edema. 5. Use in patients who do not resuscitate or intubate. 1. Community-acquired pneumonia. Community-acquired pneumonia is an ideal indication for the use of the high-flow nasal cannula. HFNC may allow patients of pneumonia to cough, mobilize secretions, and be suctioned, if necessary, all benefits that are often difficult to achieve when a patient is on non-invasive positive pressure ventilation, NIPPV. The only exception would be in patients with acute exacerbation of chronic obstructive pulmonary disease, COPD, from pneumonia, as there is evidence demonstrating a decreased mortality and need for intubation with the use of NIPPV. 2. Post-extubation. Another unique use for high-flow nasal cannula is in patients after extubation who are at low risk for needing re-intubation. High-flow nasal oxygen is an alternative strategy that may reduce the risk of re-intubation in the ICU compared with standard oxygen. A large-scale RCT has reported that high-flow nasal oxygen was non-inferior to non-invasive ventilation in preventing re-intubation in patients at high risk. Whereas high-flow nasal oxygen could be considered as a reference treatment after extubation, using high-flow nasal oxygen with non-invasive ventilation may further improve gas exchange and the work of breathing, thereby avoiding re-intubation. Hypoxemia alone. Postoperative hypoxemia? For example, pain, residual anesthetics. Hypoxemia and hypercapnia. Respiratory pump dyslundion, alveolar hypoventilation, and/or D.T.C.D mismatch, for example, atelectasis. Oxygen therapy often sufficient, low-flow or high-flow oxygen supportive therapy. Oxygen therapy often not sufficient, consider adding positive anoy pressure. 3. Pre-oxygenation prior to intubation and high-risk procedure. Intubation of a critically ill patient is a high-risk procedure with high rates of complications, including hypoxemia, hypertension, and even cardiac arrest. The high-flow nasal cannula device has an advantage compared to alternative methods, such as bag mask ventilation, BMV, and NIPPV. The high-flow nasal cannula device can stay on the patient and provide continued oxygen therapy, as well as provide positive pressure, even during the apneic period compared to BMV and NIPPV, which have to be removed during the intubation procedure. A high-flow nasal cannula may be as effective as N.I.D.C.H and superior to standard oxygen therapy for pre-oxygenation prior to intubation or high-risk procedure like fiber optic bronchoscope. In critical patients. Following picture is showing fiber optic bronchoscopy is performed in the presence of high-flow nasal cannula or NIV. 4. Do not intubate, DNI, in respiratory distress. HFNC may be an effective therapy for patients who are DNI with acute hypoxemia and mild hypercapnia, PCO2 less than 65. This therapy was well tolerated and provided acceptable oxygenation without the need for an escalation to NIPPV. This device provides both therapeutic and palliative benefits and may allow for patients to be treated outside of the ICU. 5. Cardiogenic pulmonary edema. HFNC in patients with cardiogenic pulmonary edema increase interthoracic pressure and, therefore, is likely to decrease preload. High-flow nasal cannula improve the severity of dyspnea in patients with acute cardiogenic pulmonary edema in the emergency department compared to oxygen therapy. It may be a reasonable therapy for those who are not able to tolerate NIPPV. 6. Utilization outside the Department of Intensive Care Medicine, example, emergency ward. Hypoxemia and dyspnea are also among the most common symptoms found in patients admitted to the emergency care department. Potential beneficial effects and feasibility of the use of high-flow oxygen therapy, HFOT, is found in patients with ARF, in most cases secondary to respiratory infection or acute pulmonary edema, admitted to the emergency care department, in comparison with conventional oxygen therapy. HFOT2 offers comparatively faster recovery of dyspnea, oxygenation and the rest of respiratory parameters, and the technique is better tolerated and more comfortable for the patients. In turn, HFOT does not involve greater difficulties of use than conventional oxygen therapy. The application of HFOT to the out-hospital transport setting remains to be evaluated. 7. Palliative care. In those patients in which IMV is not indicated, HFOT could be of benefit, since it reduces dyspnea and improves hypoxemia and cough. Furthermore, it is well tolerated by the patients, who can communicate and even be fed with this system. Indeed, a constant finding in many of the studies published to date is improved patient well-being with HFOT. 8. Exacerbation of chronic obstructive pulmonary disease. In the case of hypercapnic respiratory failure, HFOT could also offer benefit by reducing partial pressure of carbon dioxide and improving the pH value, probably as a consequence of the pressure increase generated in the upper airway. However, it is important to mention that the administration of high gas flows could be useful in these patients subject to the condition that we use low FiO2 levels in order to lessen the risk of hypercapnia. Furthermore, these patients with chronic respiratory disease can especially benefit from the improved mucociliary function afforded by HFOT. Nevertheless, further studies are needed, comparing the use of HFOT versus NIMV/CPAP in this patient subgroup. Equipment. The administration of high-flow oxygen therapy, HFOT, requires 4 elements. 1. A patient interface. 2. Blender of room air and oxygen, a high-flow administration system allowing control of the administered flow and FiO2, 3, a humidifying-warming system, and 4, non-condensing tubing. The air-oxygen blender allows a fraction of inspired oxygen from 21% to 100% and generates a flow of up to 60 L per minute. The gas is heated and humidified through an active heated humidifier and delivered through a heated tube. 1. Interface. The patient interface consists of special silicone nasal cannulas that are longer than the conventional cannulas. The silicone cannulas come in different sizes, and we must choose the size that best adjusts to the nostrils of each individual patient. Adapters are also available for tracheotomized patients. Choosing correct nasal cannula size. Each cannula should comfortably fit into the patient's nose and prevents entrainment of room air around the cannula, which can occur with standard nasal cannulas. Each manufacturer will also have a max flow rate for each cannula size corresponding to the size and age of the patient. 2. Blender of room air and oxygen. A system capable of administering a high gas flow, 0 to 60 liters per minute, and of adjusting the administered fraction of inspired oxygen, FiO2, is required. 2 different systems are able to do this. Mixing of oxygen and compressed air through 2 independent wall outlets connected by a tube, or using commercial respirators. Mixing of oxygen with room air by means of a turbine. 3. Humidifying-warming system. The fundamental element for clinical use of the technique is effective humidification of the administered gas. The most widely used commercial systems are Optifloatman and Vapotherm. These systems allow us to administer the gas warmed to body temperature, 37 degrees Celsius, and with a relative humidity of 100%. 4. Non-condensing tubing. A number of commercial tubing systems, non-condensing tube, heated circuit, are available. The important issue in deciding which system to use is that we need mechanisms for preventing or minimizing condensation in the tubes, since condensation has been shown to favor infections. In this device we can adjust temperature, flow rate and FiO2, and they are shown within the dial. Weaning from the high-flow nasal cannula. It is difficult to establish guidelines for weaning from high-flow oxygen therapy, HFOT, and its replacement by conventional oxygen therapy. However, it would seem reasonable to first lower FiO2 and then the flow. An acceptable recommendation could be maintenance of the administered flow until correct oxygenation is achieved with FiO2 less than 0.5. The reduction in flow should be slow, 5 liters per minute every 6 to 8 hours. Lastly, once correct oxygenation has been achieved with less than or equal to 20 liters per minute and FiO 20.5, we could consider switching from HFOT to conventional oxygen therapy. Nevertheless, some patients require the intermittent use of HFOT during the weaning phase. Contraindications and complication. No important adverse effects have been described in relation to the use of HFOT. Active humidification systems allow the administration of fully conditioned gas, thereby minimizing the side effects at nasopharyngeal level. Few complications rarely may occur, like epistaxis, gastric distension, local discomfort in pressure area, excessive PEEP in newborn may result pneumothorax, delayed intubation, while hoping HFNC will correct the things. Contraindications and complications continue. In patients with chronic obstructive pulmonary disease, COPD, the use of high oxygen concentrations can cause respiratory acidosis due to the reduction of respiratory frequency and ventilation perfusion alterations. Relative contraindications include epistaxis, nasal obstruction, recent nasal surgery, basilar skull fracture. Risk. He is doing okay, let's not intubate. In patients who are acutely unwell with HFOT, there should be a 2-hour limit on HFNC trial. It should not delay intubation. Failure of HFNC might cause delayed intubation and worse clinical outcomes in patients with respiratory failure. People say you can't live without love. I think oxygen is more important. High-flow nasal cannula. Learning pulmonology.